Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Rhonda Collins. She's a chief nursing officer. Today's Kevin MD article is Nurse-Initiated Protocols for Sepsis, a strategic imperative for patient care and hospital operations. Rhonda, welcome to the show.
Thank you so much. It's a privilege to be here. Thank
All
you.
right, let's start by briefly sharing your story and then jumping into the article that you shared with us on Kevin MD.
Sure. I've been a nurse for almost 40 years. Obviously, I've been around a while. And I started in labor and delivery. I was a high-risk labor and delivery nurse. If you were a woman just having a baby, I was probably not your nurse. You had to be ill with a HELP syndrome or, high blood pressure or something. And it was through that because I had one or more patients that I could not see. I could not touch. I had to rely on technology to give me insight to that unseen patient, the baby. And through that, I became very interested in technology and nurse adoption of technology. And so that really drove my career for the next 25 years, was just understanding how do nurses initiate workflows? How do we change workflows? How do we use technology to our benefit? And so much of my doctoral work and my publications have been on nurse adoption of technology and understanding how do we not confuse or complicate workflow when we instigate new protocols or new technologies, but how do we make it where it's an augmentation to how we work and not a frustration? So I would say that's really driven my careers. I've worked with different products and different philosophies and different organizations. I've had the privilege of working in international roles. So I get to see how nurses around the world work and adopt technology. And it's really informed everything that I've done for now and in the future.
All right. So in your Kevin MD article, you talk specifically about sepsis. And so talk about that article and, of course, how that intersects with your background in integrating technology and workflows.
Right. I mean, what I was writing about was really fundamentally workflow. How do nurse initiated protocols improve the patient experience or the patient outcome? And how do we manage that in the environment? We know that 66 to 70% of all patients presenting to the hospital come in through the emergency department.
Hmm.
There's only a couple of ways patients get in the hospital, direct admit, usually for surgery, or through the emergency room. We do have protocols for STEMI and stroke. And if you look at since we've implemented those protocols, that now STEMI is actually initiated in the field frequently
Hmm.
with the emergency services. And so they come into the hospital, and less than 1% are now admitted with an actual STEMI because we've done all this work to understand how workflow and protocols can enhance the process. If you look at stroke or stroke mimics, that's a little bit harder to figure out. Some of the medications are so powerful, they cannot be initiated in the field, but the early protocols can be initiated. They get to the hospital. Nurses then move forward with moving the patient through the system with those initiated protocols. And I, we now know that ultimately about 2.5% of all those patients are actually a stroke.
Hmm.
We can see how we've improved outcomes and treatment and urgency and all of those. So my article was really focused on we have this huge population of patients who are either infected or become septic. The numbers are such a range of actually accurately diagnosing sepsis. Make it the third S.
Hmm.
STEMI, stroke, sepsis. And let's standardize protocols. Let's standardize nurse initiated protocols because we have some in some hospitals, but we don't in others. So, nurses, where we see these protocols initiated, are seeing reduction in patient admissions. We're seeing improved treatment of patients. We're seeing shorter length of stay.
Hmm.
All of these things based on being able to accurately triage and look at the patient. Just to give you some numbers, about 41% of all patients presenting to the ED there's a suspicion of infection. But as you know, infection doesn't mean sepsis. Sepsis is a dysregulated immune response that has to be studied. There's the SEP1, there's SIRS, there's all of these things. But even with all of these protocols, we still have, are you ready for this? Somewhere between 4 and 49% end up being
Wow.
septic.
Yeah.
Isn't that crazy? So that just tells you how variable it is. So we have new technologies, we have new testing that allows us to see more accurately if this patient to rule in sepsis or rule out sepsis, just simple blood test.
Hmm.
So as we integrate that into the standing orders and the protocols, we integrate it with our SIRS and our SEP1 to be able to do just a simple blood test with a purple top that goes to the lab and comes back. We can rule in and rule out. So when I look at workflow, it's like, can nurses initiate this process and how do we improve the outcome, improve the operational workflow, free up beds, really make sure that we're treating patients in the right way when it comes to sepsis. And again, it's because there's such a variable there, and it's so, I've had people say to me, well, I know sepsis when I see it.
Hmm.
Oh, and, I mean, I wouldn't always rely on that.
Yeah.
So let's adopt new ways of looking at an old problem and improve that process.
And when you compare sepsis to the other S's that you mentioned, ST elevation MI and
Yes.
stroke,
Yeah,
traditionally there are more challenges and more ambiguity when it comes to the diagnosis of sepsis compared to
that's
the
right.
other two.
That's
So,
right.
when talking about a nurse-initiated protocol for sepsis, tell us the type of triggers that would alert the nurse to start that protocol.
Exactly. When patients present to the ED, I mean, if the nurse even just suspects infection based on vital signs, based on quick assessment, they should be able to go ahead and initiate that protocol through their EHR system and be able to then order any testing that could be presented to the physician that would say rule in or rule out. So we don't have to wait for
Hmm.
the doctor to get to the patient. That's what we're looking at. The American Nurses Association is very supportive of nurse initiated protocols, working with the doctor community, working within your organization to understand how do we set this up so the physicians feel like patients are not either being overtreated or undertreated before they can get to them. But clearly, with all the staffing issues that we have in hospitals, from the medical side and the
Hmm.
nursing side, everything, we all have to work together to ensure that there aren't any gaps. And this is just another way to close a gap and ensure that a patient doesn't fall through the crack. Because many times, as you know, we're waiting for results to come back, on lactic or blood cultures, and
Hmm.
it just delays this entire process. So, and sometimes patients are sent to the waiting room who shouldn't be sitting in the waiting room because, again, sepsis is a complication that can come on very, very rapidly. And once it's there, it's very, very difficult to manage, depending on other comorbidities with the patient.
So you talk about a emerging technology when it comes to diagnosing sepsis. So talk about that technology and how it contrasts with the traditional way we diagnose sepsis.
It's a simple blood test that can be augmented in or in addition to the assessment, the protocols that you currently use, adding the blood test. It's just a purple top that is drawn with your CBC or whatever you're doing. And in the lab, you can get results within 8 minutes or
Hmm.
so. And what this test tells us, patients will fall into three bands: band one, band two, band three. Band one is not a likelihood of sepsis. Treat the patient as though they're infected but not septic. Band three is high likelihood of sepsis. So once you have that information and can start treating, then you can order the expensive blood cultures. Then you order all the other testing that is routine with sepsis. So it does a couple of things. You have a more definitive diagnosis. You're saving money for the hospital. As you know, blood cultures can get very expensive. They're easily contaminated, all of these things that we can only do at the right time. It's instead of just doing it because we don't have a better solution.
Hmm.
So that's what we're talking about is allow that a simple blood test to make that definition and then work off of that information and continue to monitor the patient. And we've actually seen in hospitals using this testing that about 50% or more of the patients fall into band one, which is not septic.
Hmm.
So we're able to see that, yes, they're sick. Yes, we need to treat them, but it's not sepsis. So those are the things that we can look at through workflow and protocol and new technologies and new testing that we can improve what we do and augment our process.
One of the things that you talk about in your article is antibiotic stewardship is a concern, of
Yes,
course, for sepsis management. So talk to us about how these nurse-driven protocols can avoid antibiotic overuse.
exactly. It's the same process where we assess and we test,
Hmm.
assess and test. And once you have the definitive diagnosis of it's an infection or this patient is ill, then you can treat appropriately. As you know, we overuse antibiotics in general because we're not exactly sure what we're dealing with. And sometimes we have to change up antibiotics in the middle of the stream because it's not treating whatever we've looked at or diagnosed. I think all of us have had that experience. But what we're saying is reduce the the reaction of let's just administer the antibiotic because we're inspecting and we're not sure exactly what's going on. So when we talk about antibiotic stewardship, it's use it when it's necessary, be conservative when it's not.
Hmm.
And we can give you a definitive diagnosis so you can feel more comfortable in exercising that stewardship.
So, what are some of the obstacles that prevent more medical institutions for instituting some of these
Yeah.
protocols that we're talking about today?
Yeah, there's always the trust between the physicians and the nurses, and are the right decisions being made at the right time? And so that's always an issue to work on. Staffing affects it profoundly. The other part of it is whenever you have new testing or a new technology, and we're all comfortable in how we treat patients or how we manage patients because it's based on our experience, our
Yeah.
education, and all of that. So when something new comes into the environment, there is this innate distrust of it. And so I would say embrace the change, embrace the notion and the opportunity, and allow it to continue to teach you rather than just resting on this is what I've always done. And I just think that what I've always done is a trap that many of us in healthcare and in medicine fall into. It's just because we're busy, we're urgent, and we're just trying to get it done. And our past experience tells us what has or has not worked, and we get comfortable with it. So, a part of my work around technology adoption is understanding why healthcare providers adopt and why they reject. And as you know, the line between adoption and rejection
Hmm.
is razor thin. It's not even a broad, it is razor thin. Usually you get one opportunity and they'll fall off one side or the other. So that's what I would say is just be willing to embrace the notion that there is something else here that's going to give you more information that's easily integrated into your workflow.
And in your article, you cite a real world case study from a hospital, the Franciscan Missionaries of Our Lady Health System, where these standardized protocols reduce mortality by 39% and
That's
shorten
right.
length of stay and save thousands of dollars per patient, right?
That's exactly right. And I've actually worked with the director of the ED and the chief nursing officer there to tell their story because they continue to see improvements. They continue to see savings based on not initiating unnecessary blood cultures. I think in general, those run about $2,500
Hmm.
per test. They're seeing better use of antibiotics. They're seeing a more complete throughput in their ED because they're able to free up beds and move patients through. So I've actually done a webinar with them telling that story and hopefully giving them other opportunities to share that because they just continue to see the improvements. We have other hospitals in Texas who are showing these same improvements just by being willing to embrace a new way of looking at an old problem.
We're talking to Rhonda Collins. She's a chief nursing officer, and today's Kevin MD article is Nurse Initiated Protocols for Sepsis, a strategic imperative for patient care and hospital operations. Rhonda, let's end with some take home messages they want to leave with the Kevin MD audience.
Yeah, I think right now, as I look across the landscape of what's happening in healthcare, we continue to struggle with all of the issues post-COVID that have to do with staffing and fatigue. And I've had so many nurses say to me, I don't need a workbook on how to be resilient.
Mm-hmm.
I don't need somebody sending me for 5 minutes of quiet time because I'm burned out. I need people to make it easier to do my job.
Mm-hmm.
That's my number one imperative. Give me the tools I need to do my job. So really, when in my professional work, I focus on working with organizations who have new and innovative, easy to adopt, easy to use, that give exceptional results. And so that's what I'm talking about, is being willing to look at what the potential could be and look at how it could enhance, not disrupt
Mm-hmm.
your workflow and your care of patients. And I think that's the primary message I would leave as we move into a new world of AI and how we adopt that. I mean, I speak on that occasionally for nurses, talking about code compassion. How do we integrate technology into what is traditionally for nurses known as a caring profession, if you will. And so I do think that technology doesn't take that away for either physicians or nurses. It does allow you to be even more present
Mm-hmm.
when you choose to use the information that new test, that new technology, that new protocol or process gives to you. So that's my takeaway message: is adopt it, use it, and embrace that information that it gives to you, because it's going to keep changing. Nothing is ever static in this world.
Rhonda, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you. I appreciate it.